So in this short clip, we'll be looking into the differences between the acute pancreatitis versus the chronic pancreatitis. So acute pancreatitis, there's a sudden inflammation of the pancreas, which is often it's reversible. Whereas if you look into the chronic pancreatitis, it's progressive and there is irreversible pancreatic damage leading to fibrosis and loss of function. And then if you look into the pathogenesis of acute pancreatitis, there is premature activation of trypsin. So when this enzyme trypsin gets activated, it can lead to autodigestion of the pancreas, leading to inflammation. Then the chronic pancreatitis, there is chronic inflammation which can cause fibrosis. And then there is loss of the endocrine and the exocrine function of the organ. Then we'll look into the etiology of each of these acute and chronic pancreatitis. So there's a famous mnemonic we know, I get smashed. I meaning idiopathic, that means we don't know the cause of it. There is no known cause. G means gallstones, which can lead to acute pancreatitis. E means ethanol, alcohol causing accidental injury. Trauma, which can be either blunt trauma or penetrating trauma. S for steroids. Then M is for mumps. Coming under that, there are other viral causes like HIV, Epstein-Barr virus, and Coxsackie virus, and also bacterial causes like mycoplasma. A stands for autoimmune, which comes the IgG4 related plasmacytomas causing blockage of the pancreatic duct. Scorpion venom, which is somewhat rare. Then H is hypercalcemia, and then hypertriglyceridemia, and then hyperparathyroidism. Again we have E, that is ERCP. D, the drugs. The other drugs we have like azathioprine, and we have valproate, thiazides, furosemide, and tetracyclines. Next, for this we'll remember the mnemonic, tigers can hurt. So T, tropical infections or tropical pancreatitis. I, idiopathic, no known cause. G, genetic reasons like in CFTR gene mutations. E, again ethanol. And R, recurrent pancreatitis can cause chronic pancreatitis. S, strictures. And then C, congenital anomalies like pancreatic annulus, pancreatic divisum, which cause blockage of the pancreatic duct. A, autoimmune again, and a neoplasm like in adenocarcinoma causing blockage of the duct. H, hereditary. So now we'll look into the clinical presentation. How do they present? So in acute pancreatitis, they will have severe epigastric pain, and also it will radiate to the back because it's partly a retroperitoneal organ, and it is relieved when we are bending forward because of reduction in the peritoneal irritation. And they might come with nausea, vomiting, and they might have hiccups, etc. And they'll have diarrhea and dyspnea, hematemesis, or melena because of hemorrhage. Dyspnea is due to ARDS or pleural effusion. The signs, vital signs, they will have tachycardia, and they might have hypotension. They might come with jaundice because gallbladder duct obstruction. And then they might have this Cullen sign and Gray Turner sign. So in chronic pancreatitis, similarly they can come with epigastric pain, or else they can have the left shoulder pain because of the irritation of the diaphragm. And then they can come with nausea again, vomiting, and they'll have weight loss because of malnutrition, because of the malabsorption, steatorrhea because the fats are not getting digested properly, and they can have diabetes because of the endocrine dysfunction. So now if we look into the complications, acute pancreatitis can lead into systemic inflammatory response syndrome, shock, it can lead to ARDS, it can lead into electrolyte imbalance, saponification can cause hypocalcemia, and also they can have pancreatic necrosis because of the inflammation, and then pancreatic abscess, pus-filled collection, localized collection, pseudocyst can form around the pancreas, and then hemorrhagic pancreatitis because the vessels can get affected, and then splenic vein thrombosis can happen because of this inflammation. And then in chronic one, again pancreatic pseudocyst, but we might need to do a surgical intervention there. Biliary obstruction can happen because of these strictures, and then duodenal obstruction can happen, inflammation causing strictures, and then again splenic vein thrombosis and portal vein hypertension causing variceal bleeding. Pancreatic adenocarcinoma, long-term chronic pancreatitis can cause pancreatic adenocarcinoma. Then we look into the investigation. Apart from the basic investigations, we need to do the serum amylase, which will be higher, 3 times the upper limit of normal, serum lipase, serum trypsin level we can check, and in the chronic pancreatitis, those will be normal or slightly elevated. Apart from that, imaging, we'll have to do some imaging, chest x-ray, and then ultrasound scan abdomen to check in pseudocyst, CECT abdomen. In the chronic pancreatitis, we'll have to do CECT, MRCP, ERCP. So now we look into the management part. So when managing the acute pancreatitis, basically we have to do the fluid resuscitation. Depending on the patient, we'll have to give blood, also oxygen, pain management, IV antiemetics, and then we'll have to give IV acid suppressors, proton pump inhibitors, and we'll have to give antibiotics if there's any underlying infection. And then there might be some surgical intervention that we'll need to do if there is any gangrene necrosis. We'll have to remove those. If not, it can be a harm to the patient. And then lifestyle modification. They need to abstain from alcohol because that is one of the common cause of pancreatitis. And then early cholecystectomy if gallstones are the causes of this pancreatitis. And then they need to control the secondary causes. If we look into the chronic pancreatitis, alcohol abstinence, and then dietary intervention, and then they'll have to take pancreatic enzyme and endocrine supplements because those are not produced. Pancreas is damaged and they are no longer producing. ERCP depending on the cause, surgery if needed, and pain relief, which is most important. And finally, there's one important thing, the severity assessment. In acute pancreatitis, we have several scores, the Ranson's criteria, and then we have the Apache 2 criteria, and then we have the modified Marshall score, but not in chronic pancreatitis. So that's it.